In 2005, the Joint Commission identified 7,147 sentinel cases. Of those cases, almost 36% of sentinel events are due to surgical errors, and 13.4% were wrong site surgeries. Communication breakdown is the main cause of these errors. These numbers tell us that there is a gap in communication and a gap in patient care that needs to be corrected. Our topic that we are presenting to you is based off surgical errors and how we can fix that within an interdisciplinary team.
The first scenario is based off a real case study which we retrieved from the Agency for Healthcare Research and Quality.
Poor guy. He's got cancer of the kidney. Fortunately, it's just in the cortex and hasn't metastasized. We got a 54-year-old male, reported abdominal pain and hematuria. CT scan shows renal cell carcinoma of the right kidney. Could you schedule up a follow-up surgery with the OR at Hospital B?
Got it, sure. Are you sure you don't have that x-ray upside down?
Of course. Now I have to inform him. Can you call and send the medical records over to Hospital B?
Yeah, absolutely. I'll send them right over.
All right, I'm off to an important meeting.
Hospital B, this is Nurse Lexi.
Hi, Alexi. This is Meg. I'm calling you to give handoff report for a patient that's being transferred to you.
Oh, okay, go ahead.
Okay, we have a 53-year-old male who presented to our hospital with abdominal pain and hematuria. The CT scan showed that the right kidney has renal cell carcinoma, and he was sent to your hospital for surgical management.
Oh, okay. So we didn't receive any imaging yet. Was that sent over?
Yeah, I already sent it over this morning. Maybe you just haven't received it yet.
Okay, I'll keep an eye out for it. Thanks.
Thanks. Bye-bye.
I don't see any imaging in the chart, any CT scans or whatnot.
The nurse called and said we should be receiving it soon from Hospital A.
Okay. Well, the documentation looks good, and we don't really have time to wait. We need to get that kidney out. We will be removing the left kidney. Let's get the patient prepped for surgery.
All right, sounds good.
All right, Nurse Lexi, was the surgical checklist completed?
Yeah, I think so. We did the counts. Do we have the gauze we need?
Yep, we do have some gauze.
And we got the syringes.
Yeah, couple of those.
Do we have the clamps?
No, but we can get those later. That's not really important right now.
And it looks like we have the right patient there.
Yep. That good looking hair, I remember that from the talking to him earlier. I think we're ready.
I think that's about it.
All right.
All right.
10 blade.
The day following the surgery, the pathologist contacted the surgeon to report no evidence of cancer in the removed kidney. The surgeon then reviewed the initial CT scan and realized his mistake. The patient underwent a second surgical procedure to remove the cancerous kidney, leaving the patient with no kidneys. The patient was then dependent on dialysis, and because of the cancer, was not a candidate for transplant.
Have you all here today to discuss case number 476, the surgical site error. And I sit on the board for the ethics committee, and there were 4 things that went very wrong with this particular case, so I want to go over them and kind of have you each go through and explain, in your opinion, what went wrong, how we can correct it in the future going forward. So the first main thing that I wrote down here is the documentation. So it was stated that the wrong kidney was to be removed. So the physician here, you can kind of explain what your view of this is.
Yeah, absolutely. So we decided we instituted sort of policy, double check scans before documenting, and also rather than passing it off to somebody else documenting it, the person who reads the scan should be documenting it.
Okay, good. So next we have the patient transfer with no imaging. So this surgeon never looked at the images. So transferring from hospital A to B, there was no follow-up images being transferred over to the new location.
Yep, and that's just something on our end that we should have made sure that we had those images, or we could have redone the CT scans just to be absolutely certain. Because I mean, in this case, it ended up badly, and both kidneys had to be removed. Mm-hmm.
Okay, good. Thirdly, there was no pre-op imaging.
Kind of goes along the same route. Like, we just need to make sure that we have eyes on the scans before we cut into a patient.
Mm-hmm. And then lastly, implement a universal protocol and checklist.
Yeah, so the checklist we used was very vague. So as we were going through it, I don't think we hit all the necessary steps to ensure patient safety.
Okay. So going forward, making sure there is a checklist that is critical for the particular surgery should we have, or the actual unit as a whole.
I think it would be appropriate to have like a customized departmental surgery or checklist for the surgery, so then it's custom to not only the surgery but the patient, and it's just very standardized.
Yeah.
Customized. It's more customized.
It's more customized to the surgeries we're doing, and have it be a little more thorough,
Okay.
so we're not missing any crucial steps.
Okay, good. All right. Well, thank you for meeting today. I will take all of these notes back to the board, and we'll further discuss.
All right. Thank you.
Thank you.
The Universal Protocol for Preventing Wrong Site, Wrong Procedure, and Wrong Person Surgery became effective in July 2004 and applies to all accredited hospitals, ambulatory care, and office-based surgery facilities. The Universal Protocol was designed and engaged institutions in implementing a standardized approach to surgeries and procedures. The protocol includes many specific recommended steps, but the three principal elements of the Universal Protocol include pre-procedure verification, site marking, and a timeout prior to incision, which are all included in the WHO Surgical Safety Checklist. So the checklist's main goal is that no step in the process will be forgotten. So this includes eliminate errors due to fatigue, pressure, distraction, or other factors. The World Health Organization introduced the Surgical Safety Checklist in 2008. The Joint Commission mandates a checklist to be used prior to surgeries. And lastly, this helps identify the right client, the right site, and the right procedure or surgery.
I don't see any images in the patient's chart. Can you run and grab those, see if they are in yet?
Yeah, I can go check. Yeah, I haven't been seeing them either. They said they were gonna send them over. Are you sure you're looking in the right place in the chart?
Yeah, I mean, I don't see anything.
Yeah.
Maybe do you know where else to look?
That's about it. I don't
Okay.
know.
Well, I just want to be certain. Can you take the patient down for a new CT scan? I just want to make sure that we are getting the right kidney out.
Oh,
the
sure.
Correct kidney out.
Yes, I'll go run and take him to CT really quick.
Awesome. Thank you so much.
After I have those images.
Wow, you're really fast. Okay, so images shows that the right kidney does have cancer. So the documentation on the computer is wrong. We will be removing the right kidney,
The
not
right
the left.
Okay, I'll go change that on the board.
Okay.
So is that all?
I think that's everything.
We're ready?
We are ready. Let's prep the patient.
Sounds good. So we're just going to run through the surgical safety checklist before we begin operating. So could I have you state your name and date of birth for me?
Daniel Portis, January 1st, 1965.
Awesome.
New Year's baby.
And do you know what surgery we're completing today?
Taking out the right kidney.
All right, and we did get your consent earlier.
Mm-hmm.
Okay. Is the site marked?
Yes, we marked the site earlier this morning. We have the right side on the back.
They use a pen.
Mm-hmm.
Yes, exactly. All right, then we'll get the anesthesiologist in here to complete the rest of this
All right,
part.
I'll be right back.
So we have your anesthesiologist that will be working with you here.
How are you?
Just gonna run through the rest of this checklist with her. Is the anesthesia machine and medication check complete?
It is, yes.
Is the pulse ox on the patient and functioning?
Looks like it is.
Does the patient have any known allergies?
Nope.
Not that you know of. Any difficult airway or aspiration risk?
No.
And is there a risk of less or greater than 500 milliliter of blood loss?
Nope, should be less than 500.
All right. Great. That's
Okay.
our anesthesia.
Alright.
Okay. Am I gonna feel this right away?
Maybe after a minute or so. Okay, ready? We'll feel a quick poke, injecting anesthesia.
I don't feel.
All right, so just running through the checklist here, let's have everyone confirm your name and your role today.
All right, I am Dr. Roach. I am the physician on this case.
I'm Megan Lindau, and I'm the anesthesiologist today.
And I am Lexi, and I am the surgical nurse that will be out helping with this procedure today. And can we verify this patient's name?
So this is Daniel Portis, age 53, born January 1st, 1965.
And the procedure we'll be doing today?
We are removing his right kidney because it has cancer.
All right, and where will the incision be made?
On the back right side.
All right. Has antibiotic prophylaxis been given within the last 60 minutes?
Yes.
All right. Anticipated critical events?
Nothing expected. This is a routine procedure, so normal post-op care.
And how long will this surgery take?
It'll probably be less than an hour.
All right. And anticipated blood loss?
Probably less than 500 milliliters.
All right. And are there any patient-specific concerns?
No patient-specific concerns today.
All right. And we have the sterile field set up, and no equipment issues or concerns. And then do we have the imaging displayed?
All right.
Sounds good.
All right. Anything else we need to do before surgery then?
Nope.
Looks like we ran through the surgical checklist. We identified everything, and we can continue onward.
Yep. Sounds
Good.
All right. Ten blade.
All right, so the surgery is complete. We removed the right kidney from this patient. We did a complete instrument count. We have 10 gauze, 5 syringes, 10 blade, and we have the specimen labeled right here.
Perfect.
And there were no equipment problems we need to address. Are there any key concerns for recovery and management for this patient?
No, just routine post-op care, and then notify me if there's any complications.
All right, will do.
Some statistics found regarding surgical checklists include the following. A study from 2009 showed a surgical checklist is to allow the patient the opportunity for final questions in regards to the surgery, patient-surgeon interaction prior to the surgery, identification of the surgical site with the patient, surgeon, and nurse, decreases wrong site surgery, and decreases patient anxiety. In 2013, the World Health Organization introduced a surgical checklist. From this study, postoperative death rate in the hospital was reduced from 1.5% to 0.7%, reducing it by nearly half. And the second complication was reduced from 11% to 7%.
Recommendations for future practice include surgical site markings would be a part of every surgical checklist and completed by the surgeon prior to surgery. The confidence level of the OR nurse is an important factor related to the successfulness of the checklist. The use of more simulation training for healthcare workers can significantly increase the efficiency and accuracy of completing surgical checklists. And lastly, it is recommended that to decrease communication errors, a customized departmental approved surgical checklist is utilized correctly.